Yeah. Good evening, all. My name is Surekha, Marketing Manager, Microlabs. We are delighted to welcome you all to Pediatric Pathshala Module 4, Issue 1. From last 2 years, we have successfully completed Pediatric Pathshala Module 1, 2, 3, where we explored different crucial aspects of the rational use of antibiotics in respiratory tract infections. Once you entered into our Pediatric Pathshala platform, you will see this page where you need to register yourself. This Pediatric Pathshala initiative has a different scientific CME series on pediatric infectious diseases, interactive Q&A platforms, experts view to excel pediatric practice, and update on pediatric infectious diseases. All the previous module 1, 2, 3 archive sessions are saved on the Pediatric Pathshala platform. This Pediatric Pathshala Module 4 theme is pediatric infectious diseases, and today's issue 1 is case-based discussion on Staph aureus infections. For this today's session, we have scientific coordinator plus moderator Dr. Pramod Jog, who does not require an introduction, but as a formality, I would like to brief about him. He's a senior pediatrician from Pune, who is professor of pediatrics D.Y. Patil Medical College, Pune, who was president IAP 2016, who was standing committee member International Pediatric Association from 2016 to 19, who was ex-president, ex-vice president Infectious Disease Chapter IAP, who was standing committee member Asian Society of Pediatric Infectious Diseases. Welcome you, sir, once again to make this session very interactive and insightful. And to discuss the different cases, we have today's speaker, Dr. Vidya Krishna, who is Senior Consultant Infectious Diseases Apollo Hospital, Chennai, who has completed postdoctoral fellowship in infectious diseases and infection control, who has done fellowship in infectious diseases, immunology, and bone marrow transplantation from Great Ormond Street Hospital, London, United Kingdom. Welcome to you, ma'am, and it's our honor to have you on board. All the pediatricians, you can generate the certificate after completing the session, wherein this certificate is signed by Dr. Pramod Jog and Dr. Vidya Krishna on the today's topic, a case-based study on Staph aureus infections. Over to you, Dr. Pramod Jog. You can take ahead the session.
Sure. Thank you. So, thank you, Dr. Surekha, for introducing both of us. And we are going to have a discussion on staphylococcal infections, and we will try to demystify the staphylococcal infections in children. Actually, staphylococcal infections are very common in pediatric practice, and some children they get boils, simple boils. Some of them they get serious staphylococcal infections. Some children, as all of us know, following the attack of measles, may get secondary bacterial pneumonias, which are staphylococcal. Some children who get influenza, they also get secondary bacterial infection with staphylococci. All of us have heard about staphylococcal scalded skin syndrome, and then so many various infectious disorders they are associated with staphylococci. And remember that these staphylococci were discovered in 1880. Okay, and then that was the Staphylococcus aureus, and that emerged as a what you might say a potentially pathogenic organism. It's a gram-positive organism, and it can cause various diseases, as I said. And then, until the introduction of penicillin, the mortality of the patients who were infected with Staph aureus was very high. It was almost about 80%. Okay, and in early 1940s, when this Second World War was going on, these infections were treated by penicillin. And the first strains which were resistant to penicillin, they appeared somewhere around 1942. And then first they appeared in the hospital and later in the community. And this resistance resulted from what is called as, acquisition of a plasmid that encoded the penicillin hydrolyzing enzyme penicillinase. So that was the first problem which was encountered with penicillins. And since 1960, 80% of these Staphylococcus aureus isolates have been resistant to penicillin. And in addition, now they are also showing resistance to methicillin and vancomycin through the acquisition of all those MEC-A, Ven-A genes And we will discuss all this in today's discussion. So it's an interesting topic, and we have to be very careful because it is something which we can always prevent, because our hands are the ones which carry the staphylococci, and our habits of pricking the nose, and the importance of hygiene in the ICUs, NICUs, PICUs, and the training of the staff nurses for prevention. All this is extremely important. And we are fortunate to have Dr. Vidya Krishna, who is a senior consultant in infectious diseases at Apollo Hospitals, Chennai, for this particular discussion on Staph aureus infections. And through various cases related to Staph, we will explore the approach to these staphylococcal infections. So, Dr. Vidya Krishna, I request you to proceed with your presentation. Thank you.
Good evening, everybody, and thank you, Jok sir, for the kind introduction. So the objectives of my talk, I'll give you a brief background on Staph aureus, then we'll talk about the drugs which are used in the management, and we'll take a case-based approach to see how do we manage Staph aureus syndromes. So as sir rightly was talking about Staph aureus, it's a gram-positive cocci. And the unique thing is this is a leading pathogen in many pediatric infections worldwide. And it is known to cause a lot of syndromes, from simple superficial skin and soft tissue infections to deeply invasive, difficult to treat infections like endocarditis, bone and joint infections, and also shunt and prosthetic related infections, because staphylococci have what is known as a biofilm adherence. So they really go and form strong biofilms, and that's why they can cause both device-associated infections as well as prosthetic infections. There are a number of virulence factors. Staphylococci is a highly virulent pathogen. Though we know that maybe around 30% of the population can be colonized with Staph aureus, but when it has a virulent potential, when it starts producing disease, it can be really a dreadful bug. It has various enzymes, toxins. We all have heard about the PVL toxin, the toxic shock syndrome, which is again caused by a toxin, exfoliative toxin associated with staphylococcal scarlet stitch syndrome. So there are unique virulence factors because of which it is known to cause invasiveness, as well as it also has the ability to evade the host response. It's MRSA, as sir was talking about, it's no longer only a healthcare associated problem, it's also there in the community. Luckily for us in India, as of now, vancomycin resistance is not common, it is sporadically reported. So if you look into the epidemiology, this is about the Indian data. This is ICMR's data, like around a year ago. So Staphylococcus aureus, among all the isolates, if you see, it's more common in the ward and the OP to have Staphylococcus, because most of the samples that you will grow Staph aureus is usually pus. So around 8 to 11% is this, and 4.5% of ICU. So it's in Indian ICU, Staphylococcus is not a major pathogen, except in NICU, where it can be a dreadful bug. And if you see our country, the prevalence of MSSA and MRSA is almost equal. And when you look into MSSA, when we say MSSA, it itself means that the organism. So as sir was talking to you about penicillin, penicillin was the first drug, but now almost universally staphylococci, at least 93-95% of the staphylococci are no longer sensitive to penicillin. So the first drug that we can use itself is a penicillinase resistant penicillin like methicillin, cloxacillin, and other things. So the commonest oral formulations that are available for methicillin sensitive Staph aureus are cefalexin, cloxacillin. Amoxiclav is generally considered a little broad spectrum, but still it works for MSSA. And clindamycin is a drug which you can use when you have penicillin allergy. If you want to look into the parenteral options, cefazolin, cefuroxime. Cefazolin is first generation, cefuroxime is second generation. First generation are generally preferred over second and third generation cephalosporins in Staph aureus management. Cloxacillin, daptomycin is one drug which is unique because it has equal action on both MSSA and MRSA. But if you think that vancomycin is the very good drug, and so it should work on both MSSA and MRSA, that's wrong. Studies have shown that vancomycin can have higher mortality when you use it for MSSA compared to, say, cloxacillin or cefazolin. So it's a very poor choice for MSSA. If you look into MRSA itself, like as sir was telling, MRSA can usually gram-positive bacteria, they have a resistance mechanism by what is known as the MEK gene. So again, MRSA is quite common, like worldwide, around 5% of the children are supposed to be colonized. And if you look into any infection like Staph aureus infections, among it, at least 15 to 20% of infections will be by MRSA. It's continuing to raise. So are there any risk groups where you would see MRSA? So MRSA typically is supposed to be more common in dialysis population or people who have some healthcare exposure, anybody who has had a previous colonization or IV drug addicts. These are usually common reasons why somebody would acquire an MRSA. In children, typically it would be the very young children or somebody who does contact sports. They are supposed to be easily liable to get MRSA. The prevalence, as I said, is 42% among all Staph aureus isolates as per the ICMR report, and it can cause various invasive syndromes. So when you're talking about drugs, like we talked about drugs for MSSA, for MRSA, what should not be used, I'll tell you first. Penicillins, cephalosporins, except the 5th generation ceftaroline, they should not be used. Carbapenems don't work. Tetracyclines do work like doxycycline, but again, in children less than 8 years, you cannot use it for more than 21 days at a stretch. Rifampin works, but it should never be used as a monotherapy. There are very specific situations like prosthetic valve endocarditis, device-related infections, where you sort of add into another drug once the bacteremia is cleared. Quinolones, again, though it is often reported on the report, they are supposed to be not very great drugs for treating MRSA. I think I should add erythromycin also, macrolides. Though they are often reported, these drugs are not to be used in the treatment. So then comes the thing of CA-MRSA and HA-MRSA. So generally, CA-MRSA is like what would you like it's more common in the community. So I think, sorry, this part is HA and this is CA. I think it's reversed. CA-MRSA is more common in the community where you would have skin infections. And then these are, again, as I said, young athletes, people who are in close contact, like military or something like that. So these are the ones who will easily harbor it. So here they are known to have Pantone 1 leukocidin, because of which they can cause severe necrotizing skin and soft tissue infections, pneumonia, shock and toxic shock and all those things. HA-MRSA, on the other hand, is something which you acquire only when you are in a hospital. These are typically multi-drug resistant. They are only sensitive to vancomycin and teicoplanin, and they do not produce toxins, but they can cause a lot of hospital-acquired infections. Now they say that this thing is blurred, and even in the hospital, if you get an MRSA, it's still more likely to be CA-MRSA than HA-MRSA. So again, when you talk about antibiotic choices, vancomycin, teicoplanin are the drugs of choice. Linezolid, daptomycin, ceftaroline are other drugs which will act. Tizicycline, fosfomycin are very broad spectrum antibiotics, but if you have a polymicrobial situation where you also want to cover MRSA, then these drugs might act if they are sensitive in vitro. And other oral options that you have are clindamycin, clotrimazole, and doxycycline. So vancomycin is the gold standard. So dosing is 15 mg per kg Q6 hourly. It's higher than in an adult. And clindamycin is again a good drug for both IV and oral, especially if you're talking about skin and soft tissue infections, bone and joint infections, etc. Teicoplanin is a good alternative to vancomycin because it is less nephrotoxic. But remember, it has poor CNS penetration. Linezolid, again, available as both oral and IV. Again, it's a good drug for pneumonia and skin and soft tissue infections. It's very bad for bacteremia because it is bacteriostatic. Daptomycin, I already said, it's like a salvage option. We'll talk about it later. So then clotrimazole, excellent drug, especially if you want to treat somebody in the outpatient with, say, MRSA, skin and soft tissue infection. It's a very good drug. So this is a simple 2 cases that I will show you. So this is like how a typically a staphylococcal skin infection, commonest one that we would see in the OP would look like. So this is like a bullous impetigo. The second one, as sir was talking to you, this is like a neonate who has a lot of exfoliation in the skin, bullous disorder. So this is what is the scalded skin syndrome. So scalded skin syndrome, here again, generally very common in young children, neonates, exfoliative rash is a striking feature. Generally, these kids are very sick and irritable, and they have extreme tenderness when you handle them. And they can also have perioral crusting. But the way to differentiate it from drugs related allergies like SJS and all that would be mucous membranes are typically spared. And generally, they might not look like very ill, but they can be like they can even not have a fever. But because of the skin peeling, they can often get dehydrated. And there is the classic Nikolsky sign where you stroke on the skin and it will separate at the epidermis level in SSSS. So these are caused by specific toxin producing Staph aureus. So when you're talking about management of such a syndrome, like it's usually bullous impetigo, typically it's localized. You can just use topical mupirocin 2% ointment twice daily. And usually a course is 5 days is enough. Sometimes you might have to extend up to 10 days. And in the outpatient, where you're worried about, say, Staph aureus in your setting, it's important to know what's the prevalence of MSSA or MRSA. Like in my setting, it's almost 40-50%. Each is like it can be equal. MSSA and MRSA are almost equal, but there are some centers where MSSA is 80% prevalence. So you have to know your local data when you want to decide on our antibiotics. But cefalexin, cloxacillin are good drugs when you are wanting to cover MSSA. Whereas if you're not sure or whether MSSA or MRSA, then probably I would try to treat for MRSA like with clindamycin, cotrimoxazole, doxycycline. These are excellent drugs for skin and soft tissue infection. For an impetigo, I would use it only when it is extensive or it is spreading and maybe there is a cellulitis or something like that. In scalded skin syndrome, again, most of the thing is about supportive therapy, hydration, and the care that you give. And empirically, we would always start with drugs like cefazolin or cloxacillin to cover for MSSA, vancomycin or teicoplanin to cover for MRSA, and we would add a toxin inhibitor. Clindamycin and linezolid both are protein synthesis inhibitors, and they both have antitoxin effect. So either one of the two we can add. Some centers, they have started to see a lot of clindamycin resistance, so there is some hesitancy in using it. But it should be okay if you want to use it for a short course, like your toxin prevention is usually that drug is given only for 2 to 3 days till the shock resolves. So in that situation, you really don't have to break your heads too much. You can still use clindamycin. And generally, after having started this, once you have a 48-hour culture report, based on it, you might want to modify to either a single MSSA or MRSA agent, and you would knock off the protein synthesis inhibitor. So the role of topical antibiotics itself, when I'm talking about mupirocin and all that, generally impetigo, folliculitis, small wounds, and again for decolonization, we use these kind of drugs, not to be used for larger wounds or deeper wounds. Again, recurrent SSTIs, this is a common problem that we see, especially with Staphylococcus aureus, because of multiple reasons. One thing is, as sir was rightly saying, hygiene is a big factor when you're talking about Staph aureus. If you don't pay attention to proper hand hygiene or wound care, or if you keep on touching this wound and not doing proper hand hygiene, you will be spreading it to your surroundings and then you will get reinfected. So again, person to person transmission has happened. There can be silent colonizers who are sitting around you. So all those things are very important. That's why hygiene is the number one thing that you should do. And there are some predisposing factors, generally more common in adults like diabetes. In children, it would be somebody with an underlying predisposition like CGD. So if you have a recurrent deep-seated abscess, you might want to think of those things. Antibiotic prophylaxis itself is not often recommended unless you really want to break a bad cycle of recurrent skin and soft tissue infections. But usually it is the last resort that we will do. But decolonization is something that we can always advise our patients. So what they typically ask to do is to do a nasal mupirocin, like twice a day application, morning and night, for about 5 days is what is recommended. Sometimes you might have to do it repeatedly over a period of 3 to 6 months, like the same 5 days application, 5 days per month for 3 to 6 months before they can get rid of it. And chlorhexidine body wash, the surgical body wash that we use, 4%, again is recommended. Bleach solutions are recommended, but I think in India it's difficult to get anything proper. So we generally recommend this chlorhexidine body wash. And generally we say that use it for a period of 10 to 14 days. And then that is also helpful in decolonization. So with that, we'll move on to the second case. This is a child with a bone and joint infection. So this is a 2-year-old child who is admitted with high-grade fever, swollen and painful knee. And there is no apparent features that you can pick up, risk factors. Child is febrile, tachycardic, and has a swollen and red knee with a restricted range of movements. There's no focal tenderness. Counts are high, platelets are okay, hemoglobin slightly low, CRP is quite high. Ultrasound is already showing a effusion with some septation. So definitely there is a joint involvement and there is joint space widening with no bone involvement. So this is typically a what we would call is like a septic arthritis, isn't it? So what are the common etiological agents and what would be your empirical choice? So this is what we'll be discussing next. So when you look into it, septic arthritis of this child probably has left knee septic arthritis. In children, almost always bone and joint infections are secondary to hematogenous spread. So the child could have had a minor trauma or something like that, and then the Staph aureus could just dislodge into the bloodstream and affect the bone. So Staphylococcus aureus is the commonest pathogen. And MRSA, as I said, in some studies, it can be as high as 50%. Streptococcus pyogenes is the other major gram-positive cocci. Pneumococcus, H. influenza, Kingella kingae, again, and sometimes in neonates, you would also see gram-negatives and candida. And in child with sickle cell anemia, you would think of salmonella. So other things are rare. So the empirical choice, when you have a patient like this, where you are thinking that Staph aureus is the predominant pathogen, definitely you might have to cover for MRSA if your local prevalence is at least more than 10 to 15%. So less than 5 years, we would normally give these children anything like cefazolin or ceftriaxone. Ceftriaxone, any ID people really think that it is not a very great MSSA cover. So we hesitate to use it for an MSSA agent. But cefazolin is a very good choice, and you would use it with any of the other drugs for the MRSA activity. So you might want to use, if your clindamycin resistance is high, then you might be left with only drugs like vancomycin or teicoplanin. Both cefazolin and ceftriaxone would cover the Kingella kingae. Above 5 years, again, you don't, the cefazolin, the same combination is good enough. Neonates require different strategies like meropenem piptase to also cover your MRSA. So this is about empirical choice. So, but anyway, in this case, once we drew the blood cultures and the arthrotomy also was done, the pus typically shows a gram-positive. This is a typical, this is from the net, but then this is, I put this because it's very typical. The grape-like clusters, that is how you would see a Staph aureus, sorry. So this is a report. Now, this if you can see, this is how the antibiogram of Staph aureus looks. So they test for oxacillin, they test for both clindamycin and erythromycin, trimethoprim, sulfamethoxazole, cipro, doxy, and linezolid. Here, they have not reported vancomycin and teicoplanin and all that because, again, this is an MSSA. If you can see, this is oxacillin, which is sensitive, which makes it methicillin sensitive Staph aureus. So here they would not report vancomycin or teicoplanin. And just because it is a bone and joint syndrome, they have reported linezolid. Otherwise, they will not report that also. So clindamycin, again, when you want to interpret the sensitivity, you should look into what is known as D-test. So both are sensitive, no problem. Both are resistant, again, no problem. You would just not use. But if clinda is sensitive and erythro is resistant, then lab has to interpret what as a D-test. If D-test is positive, then clindamycin inducible resistance is there and you cannot use it. Other drugs here like cotrimoxazole, clindamycin are again also very good drugs for bone and joint infection. So here we have an MSSA. So generally, if you have a bone and joint infection, initially you would start with a parenteral therapy and then you will move on to oral therapy. So the parenteral therapy, if you have an MSSA like our patient, the choice would be cloxacillin or cefazolin. An alternative would be daptomycin. Ceftriaxone again and cefuroxime are not great choices. I'm just putting it because it's still there in the picture. Cefalexin, cloxacillin, clindamycin are all good oral step-down options. MRSA, again, teicoplanin is generally preferred in a setting like this because it's once a day dosing. Vancomycin, again, more nephrotoxic, and then you have to give it multiple times, like three to four times a day. So it's generally not preferred. You can do teicoplanin as outpatient therapy. Dapto, phosphonol are extreme. We would not want to use it unless we don't have a choice. Linezolid, cotrimoxazole, clindamycin, and then with or without rifampicin, especially if you're thinking of chronic osteomyelitis, device-associated infections, then maybe adding a rifampicin might be useful. When can I switch from parenteral to oral? There is no defined criteria. So these are the standard guidelines. Once the child becomes afebrile, signs and symptoms are resolving, CRP is returning to normal. And when you have a good oral agent, that is very important. And CRP, generally, they say that anywhere between 20 to 30 or at least 30 to 50% of the peak, if it is reached, then you can consider switching. Again, remember that in bone and joint infections, usually when we say, like, if it's a septic arthritis, you would treat for 2 to 3 weeks. If it is a bone and joint infection, maybe 4 to 6 weeks. But some situations like MRSA, or when your child is not responding well, or there is a complication like an abscess or something, you would want to individualize treatment and treat it for a longer time. Again, young infants, and where you have limited oral options, you just want to treat it longer. So this child also had an MSSA bacteremia. So sometimes in practice, we do have children who come in with MSSA bacteremia. Either it can be like say a secondary to a pneumonia or a bone and joint infection or whatever. So what are the drugs of choice? When we talk about MSSA bacteremia, we typically talk about two groups of drugs: anti-staphylococcal penicillins, cloxacillin, fluclox, and nafcillin. The clox and fluclox are there in India. Nafcillin is not there. Or a first generation cephalosporin like cefazolin. And the daptomycin, as I said, is a drug alternate choice, but it's very costly. So whenever we talk about Staph aureus bacteremia, there are certain management principles. You always have to anticipate who will go in for a complicated Staph aureus bacteremia. When I say complicated Staph aureus bacteremia, means they do not differ worse early and they continue to be developing complications, metastatic complications while on therapy, or blood culture is persistently positive. Nowadays, the definition is as early as 24 hours. So, like anything beyond 24 to 48 hours of therapy, appropriate therapy, if the patient is still continuing to flag Staph aureus in blood, then we call it a persistent bacteremia. So these are more common in children who come in with the community, not in your hospital hemodialysis patients and those kind of situations. Lying associated infections generally do not become persistent unless there is already an endocarditis or something happening. Usually community acquired persistent positive blood cultures, I already told you. So in Staph aureus bacteremia, the dictum is after you have started therapy, at 48 hours, you will repeat a blood culture to check clearance. That has to be done in every patient, irrespective of immunocompetent, immunocompromised, age, anything. Because the duration of therapy itself is determined by that. Because if you continue to have persistent bacteremia, then you know that your child is going to be having some metastasis sitting somewhere or an endocarditis. Automatically, the duration of therapy goes beyond the 2 weeks point. So the minimum duration is 2 weeks in an uncomplicated bacteremia. But once it becomes complicated, it is 4 to 6 weeks or longer. So MSSA, I already said. MRSA, again, the drugs of choice would be drugs like vancomycin or daptomycin. We'll talk about that again. So when you're talking about the MSSA drugs like anti-staphylococcal penicillin and cefazolin, so is there any difference? Should I be choosing one over the other? Cloxacillin has been the traditional drug of choice. But again, in children, we know that it's difficult to sometimes get the drug, or thrombophlebitis is a big problem. So we don't sometimes have to resort to alternative drugs like cefazolin. Cefazolin also is not sometimes readily available, but at least in the south, we don't have problem with this. We always seem to have stocks for this drug. So cefazolin, again, there is no head-on-head trial comparing cefazolin and clox, but from observational data, people believe that cefazolin is at least equivalent, if not superior, to anti-staphylococcal penicillins. So, as this I've already told you, cefazolin is only in the parenteral form. The oral component would be the cefalexin. There is cefazolin is not subject to cloxacillin is not subject to inoculum effect. That is a major limiting factor with cefazolin. So when you have a high bacterial load like endocarditis or a bone and joint infection, typically there is a worry that cefazolin might fail. This again, this is theoretical concern as of today. We don't have any proven studies to demonstrate this, but this is always a concern when you are using cefazolin. So you have to be extra careful. You have to make sure that you're repeating cultures, make sure that you're monitoring treatment response by either biomarkers or clinical response when you are using cefazolin in situations which I told you. Staphylococcal penicillins again are the only drugs that you can use when you have a Staph aureus meningitis, like a shunt-related meningitis or something. Cefazolin has very poor CNS penetration. But again, this is slowly, some people seem to think that cefazolin, if you use in high doses, it still penetrates. But I don't think anybody, it's there in the guidelines set to start using cefazolin for a CNS infection. But in between cefazolin and cloxacillin, cefazolin is definitely better for bone and joint infection because cloxacillin has high protein binding and it doesn't get into the tissues that well. So tissue penetration of beta-lactams is anyway low. So if you're using either of the drugs, make sure that you're using very high doses. Unlike linezolid, clindamycin, cotrimoxazole and all, where tissue penetration is very high, these drugs like clox and cefazolin have very poor penetration. So you have to use high doses. And there is the theoretical concern of inoculum effect. So this I already told you again. So PK/PD wise, both acidyl drugs inhibit the penicillin binding protein. Time-MSSA is useful, so you have to use higher doses, frequent dosing, and protein binding is high. This I told you. Dose adjustment in renal failure. Clox is the only thing which is available orally, and bioavailability is it's average, so it has to be taken with food. So the dosing is 50 to 200 mg per kg per day, quite variable, but I will always use a higher dose if I'm using clox, especially because if you're treating a severe infection, you want to use the higher dose. And again, capsules, injections are all available. Cefazolin, again, 50 to 150 are on the higher side of 150 when you're treating bone and joint infections. Use maximum dose in IE as well as bacteremia. Maximum per day is 6 grams per day. Again, injections are available. Adverse effect, not too much. Phlebitis is a major one. Orally, GI side effects are again common. C. difficile is surprisingly supposed to be common with cloxacillin. Candida again can happen, especially if you are using prolonged therapy. Cefazolin, again, GI side effects, hypersensitivity. But the only thing that we can remember about cefazolin is it does not share the same R1, R2 side chain with any other beta-lactam. Hence, it's quite safe even in patients with penicillin or cephalosporin. It's a unique beta-lactam. So that way it's sort of, that's why even in surgical prophylaxis, in a patient with say penicillin allergy, if they are using cefazolin, you can just safely use it. It's not supposed to be cross-reactive. Phlebitis, fever, and other complications like cytopenia is common with both cefazolin and cloxacillin. Drug interactions are there that if you're using on prolonged, you might want to look into these things like oral anticoagulants and all those things. But the main thing about cloxacillin, I would say, is avoid using it as an amoxiclav-clox combination. It's irrational and it adds to the side effects. Don't use this combination at all. Cefazolin, again, the same type of rifampicin, you will have some coagulopathy. Can't use it with live vaccines. Other indications are MSSA, infections, SSTIs, pneumonia, meningitis. Again, clox is the drug of choice. Cefazolin, except meningitis, especially in bone and joint infections, it's supposed to be better than clox. And as I said, it's a common drug which we use for surgical antimicrobial prophylaxis. So both these drugs are excellent. Cefazolin used in high doses for bone and joint infections. Oral bioavailability is not great, so you have to be careful. The next case that I'm going to show you is a 8-month-old boy who was admitted to a PICU with dengue fever with warning signs, transaminitis, and thrombocytopenia. He was managed with IV fluids via peripheral cannula. He didn't have any urinary catheter. He sort of improves and he goes to the ward, doesn't receive any antibiotics in the ICU, so he's almost getting ready to go home. But at that point in time, he develops a high fever, and within 12 hours, he decompensates and is shifted back to PICU with respiratory distress and poor perfusion. He requires HFNC, he requires vasopressor support. Now a new line, a central line and an arterial line are inserted and blood cultures are drawn. Again, still his hemoglobin is low. Counts are not, actually have dropped a little bit from 9,000 to 5,000. Differentials are fairly neutrophilic. Platelets have recovered and CRP is pretty high. So this is a very common scenario during the dengue season. Almost every year you would see at least one patient, if not more. So this child actually had a thrombophlebitis and secondary bacteremia because of that. So it was a peripheral line related sepsis. So he was, because of this, initially on suspicion, he was started on vancomycin and piperacillin-tazobactam. But within 36 hours, 2 out of 4 bottles gram positive cocci. And this is the report. So unlike the previous report, here if you see, oxacillin is resistant, which means that this is MRSA. And here you can see that Clinda is sensitive, but erythromycin is resistant, and they have also told you D test is positive. So this is typically how it behaves. Vancomycin, teicoplanin, and all that are sensitive. So treatment options are, now we have a whole lot of things that we saw are sensitive. So what do we do? So vancomycin is the drug of choice in a bacteremic condition. And generally the problem with vancomycin is, very often when I prescribe, every day I will get a call saying that the child has developed allergy. So true vancomycin allergy is extremely rare. Redman syndrome is very common. So most of the times we have to instruct the nurses to give it very slowly. Like I just tell them, you double the time and double the infusion volume and just give it very slowly. Sometimes you can even give it as a continuous infusion. They seem to tolerate that better. Teicoplanin is again less nephrotoxic, but again we don't have head-on-head trials. So efficacy is what we have from clinical observational studies. The only advantage is you don't need a TDM for teicoplanin. Again, it's not available also. Dapto is an alternative. The only problem with Dapto is it's inactivated by the surfactant in the lung. So you might cannot use it in a pneumonic syndrome, and it can cause side effects like rhabdomyolysis and eosinophilic pneumonia. Ceftaroline is a drug which is available in India, but unfortunately it is not approved in children. Though in the Western world, it is quite often used, especially for MRSA. It's a 5th generation cephalosporin. So it's very often used for your MRSA pneumonia, bacteremia and all that. And generally for a persistent bacteremia or endocarditis, it is used in a combination with daptomycin. Linezolid should not be used in a situation like this, where you have a bacteremia. Clindamycin, cotrimoxazole, they all cannot be used as a standalone drug in bacteremia. That is very important to remember. So again, these two drugs, vancomycin and teicoplanin, they again act by inhibiting the cell wall synthesis and act only on gram-positive cocci. If you look into India, so this point is important. Whenever we are talking about vancomycin, we have to look at the MIC. So the CLSC, the break point for vancomycin is, it is reported as sensitive when the MIC is less than or equal to 2. So the disk diffusion, so you cannot use a zone diameter size to interpret MRSA susceptibility. That is not recommended. So generally, when your patient's isolate shows an MIC of more than 1.5 to vancomycin, then the clinical failure is known to happen. So even though the sensitivity is cutoff is less than or equal to 2, some people even say above 1, you be very careful. You expect that it will start failing. Vancomycin is not that great drug. That's what we know, but that's the best drug we have had for MRSA so far. But still, we have to remember this caveat. Resistance, as I said, it's only a handful of reports are there. So true vancomycin resistance is not there in India. So please, if you see a report with vancomycin resistance in India, double check the quality of the report. In enterococci and other pneumococci also, you might have some issues. So bactericidal, again, time above MIC. Here, it is both concentration and time dependent. That is important. So when the area under the curve is what is important. So this is the 400 to 600 is the expected PKPD target. Sorry. I don't know why it moved. Yeah. Both these drugs actually are excreted through the kidney. CNS penetration is good only for vancomycin. Teicoplanin does not go into the CNS. So dosing, all of us should know. Remember that vanco we all remember, but teicoplanin has a higher loading dose in children. 16 mg per kg in the neonates. And in more than 2 months, it's 10 mg per kg. So you have to remember this maintenance dosing is also higher compared to adults. So that is something that we need to know. Yeah, a lot of side effects, especially what we see in practice is Redmond syndrome, cytopenia, neutropenia, thrombocytopenia, occasionally hypersensitivity reactions or interstitial nephritis. These are all common. So between the two, teicoplanin is obviously has less side effects, but still, when you are having your drug patients on prolonged administration of these two drugs, you have to monitor creatinine, WBC count, hearing, especially if you are using it along with, say, amikacin, gentamicin, and TDM, preferably for vancomycin. So again, a lot of, see, this empiric thing I will stress a little bit. So vanco and teco can be equally used whenever you have a severely ill patient with SSTI, pneumonia, bone and joint infections. Febrile neutropenia, equally you can use. Nosocomial infections in the ICU also you can equally use. But if you have a meningitis, vancomycin is preferred. Endocarditis, vancomycin is preferred. Definitive therapy, again, yeah, you have, they can be used in all the MRSA syndromes. Teicoplanin is again used preferably in bone and joint infections because it can be used for outpatient antimicrobial therapy, but it cannot be used in endocarditis. These drugs are also used rarely for shunt meningitis, ventriculitis as intraventricular or sometimes in PD peritonitis for intraperitoneal administration. So this child, who, if you can go back to the dengue child with with a gram-positive cocci, which was found to be MRSA, this child was placed on contact isolation. Very, very important. Otherwise, it will spread to all the other children in the unit. So you have, as soon as you identify MRSA, you have to put the child in a separate cubicle or a separate room, have 1:1 nursing. Then you have to use gowns, gloves, all the appropriate PPE before you handle this child. Dedicated equipment, everything should be there. So here we continued vancomycin and stopped the piptas. This child was still febrile after 48 hours, though the oxygen requirement and shock and all came better. So now the X-ray, if you can see, is showing a sort of a right lower lobe pneumonia. And now I was talking to you about MIC, importance in MRSA, isn't it? So this isolate at least has a vanc MIC of 1. So this is sort of safe. You would expect this child to respond to vancomycin if all the other caveats are met. So now what do you do? So MIC breakpoint, what is the clinical relevance? So in this child, because the MIC was still quite low, we decided to continue and gave blood cultures. But then in these situations, it becomes very, very important to look for complications. If you see Staph aureus bacteremia persistence, or if you see that the child is not behaving as you expect the child to recover, then you have to look for complications. So transthoracic echo, we did, vancomycin TDM we checked, and creatinine also was rechecked. So this child was still febrile, oxygen requirement coming down, but still there. But transthoracic echo showed no vegetations. In children, generally TE is not required. Transthoracic echo itself is enough to say that there is no endocarditis. And the TDM was 13, which is typically low for a situation like this. You want it to be above 15 to 20. So TDM for vancomycin. So you would do it in a situation like this, where you have serious MRSA infections, or if your child has a dynamic renal function or dysfunction. Previously, it was 15 to 20. I mean, that is the guideline recommendation. Now, as I said, AUC by MIC is supposed to be better. 400 to 600 should be the target when the MIC is less than 1. When MIC moves up, your target also moves up, but it might no longer be a safer drug. So this is how you calculate. You take the target level and then you measure the measured level. This is when you're using the trough level. So target level by measured level into current dose. So if you do that, suppose your measured level is 12 or 13, like what we had, target is 17, your current dose is 1750, then 17 by 12 into 1750. That's how it goes. That's how you calculate the formula. So this is the area under the curve that I was talking about. So this is just to show that. So this child, repeat culture, still continued to grow MRSA, but by then this abscess slowly started manifesting. So this is why we should do a daily head to foot examination in such patients, because unless we examine closely, you will miss out on these kind of complications. So this abscess, unless and until it is drained, this child is not going to get better. will continuously have embolic into the bloodstream and will continue to flag MRSA. So again, the common sites, again, vertebral osteomyelitis is supposed to be common. We have seen a lot of kids developing pyomyositis, thigh abscess, intramuscular collection. So please make it a point to examine thoroughly. Every day we have to examine, more than once a day also sometimes. So this abscess was drained and the pus grew MRSA. And after we drained, finally the child developed. So the metastatic complications are known to develop while on therapy. That is what we should know. As long as the MIC is less than 1 and as long as your trough level is reasonably okay, we don't have to worry about changing the drugs. We have to concentrate more on doing source control. We have to look for a drainable source and clear it, or we have to look for endocarditis. So 2 weeks we gave IV and then we completed with 2 more weeks of oral linezolid. So this is what we would do. Uncomplicated Staph aureus bacteremia means any catheter which was there was removed. The negative culture follow-up blood culture at 24 to 72 hours. The child diffused within 72 hours. Echo showed no endocarditis, no evidence of metastatic complications, no intravascular prosthetic device. If you have all these, then you call it uncomplicated. Here you would only treat it for 14 days. Whereas anything above that, like for persistent positive or persistent fever or echo endocarditis or metastatic, you have to treat for 4 to 6 weeks. So one word on persistent MRSA bacteremia, like what our child had, as I said, source control is the predominant thing. In adults, generally they do a lot of PET CT in such situation because sometimes if you're not able to localize where the pus is sitting, then you have to do something dramatic like a PET CT, like it could be in the vertebral osteomyelitis, it could be a thigh abscess. In children, generally they are easy to examine, and so a PET is not often needed. I have used it at least in only one case of my MRSA where we had a post-op MRSA persistent bacteremia in a cardiac child. And then we had to, after we got a PET, then we discovered one intramuscular abscess and drained it. So PET is not something that we do very often in children, but in adults, it's supposed to be more helpful. Check vancomycin MIC, as I said, if it's more than 2, even more than 1.5 to 2, switch to alternative agents. Daptomycin generally requires second agent because daptomycin will develop resistance quickly. So clogs, surprisingly, we have found that when you use daptomycin with first MSSA agents like cefazolin, ceftaroline, clogs, they all seem to increase the sensitivity of daptomycin. So restore the sensitivity of daptomycin. So that's why they are used. So there is a big trial again where they looked at vancomycin or daptomycin along with either nafcillin or flucloxacillin, and they found that in patients with the patients with persistent Staph aureus bacteremia were significantly lower when they used this combination. Okay, so all-cause mortality though was not different, and the rate of kidney injury again was higher when they used a combination. So this is something that we need to keep in mind. So PET CT again in adult, again we sometimes will have to do it. So we can remember that sometimes you will do it early, sometimes you will do it late. So typically if it is a very severe presentation or poorly responding to therapy, you want to localize what is the source, you would do it early. Impact, if you want to do early source control, or if you want to improve the survival in these situations, you would do early. Late would be if you had a prosthetic device or if you have an unknown source, the child is still continuing to have Staph aureus bacteremia, or if you want to decide whether it is safe to switch from IV to oral. Those situations you can do a late PET CT. So with that, I think I'm coming to the last part. Of this case, actually, it is metastatic complications are common in MRSA bacteremia. So vancomycin MIC creep, I told you about the sensitivity, the MIC between 1.5 to 2 or more than that. One point I should tell you is, if you have linezolid, I did mention that it is a bacteriostatic drug. So be very careful when you're using only linezolid standalone in your septic patients. Sometimes if you have a bacteremia, it might not work very well. So that brings to us to the last slide of this talk. Staph aureus is an important pathogen, especially in SSTIs, BJI, pneumonia, sepsis, and especially in patients with prosthetic devices, chronic granulomatous disease, and hyper IgE syndrome. The main thing about Staph aureus is MSSA and MRSA have different choices of treatment. So you have to be guided by that. And treatment can have unique challenges. I think I showed you 2 cases where we had different kinds of problems, and source control is very important. And recurrent SSTIs, I did talk to you about decolonization protocol. So with this, I'm happy to stop and take questions.
Thank you. Thank you, Dr. Vidya. It was a brilliant exposition of this particular topic. And it was case based, all our listeners would know the management as the case progressed on day-to-day basis. We have some questions which appear to be very basic, and one of them is about the role of coamoxiclav in the Staphylococcus aureus infections, and whether this molecule can be used for the treatment of Staph aureus.
Yes, amoxiclav, as I said, it has anti-penicillinase effect. So most of the times when you have an MSSA, as I said, you only have to overcome penicillin resistance. So that it will do. But generally, amoxiclav is supposed to be a little bit more broader spectrum. It also has a little bit of gram-negative coverage. It can still cover your E. coli, Klebsiella. So, I mean, E. coli at least, if not Klebsiella. So that's why we want to use drugs which are more narrow, like, say, cephalexin, cloxacillin. Cloxacillin especially is very narrow. It's only gram-positive. So you want to use drugs like that. But you're not wrong in using coamoxiclav. Just use good doses.
Sure. Someone wants to know about the place of all these antibiotics in relation to the aware classification of WHO. So, which of these antibiotics that you mentioned come in that category of aware classification?
The clindamycin, I mean, except cotrimoxazole. I think cotrimoxazole is the only thing which comes in the access group. The in-between ones would be all your cephalosporins and the watch category. Clindamycin would be in the watch category. And the vancomycin, linezolid, daptomycin, and zactorylene and all those things will be in the reserve group.
Okay, that's great. And then someone wants to know the dose of cephalexin and cloxacillin and amoxiclav in the management of skin and soft tissue infections by staphylococci. Yeah.
That's like, I always check my drug dosing book, but I will tell you what I have in my mind. I still check because every day I think drug dosing is something which is very, very important for children. When you manage children, you should not make any mistakes in that. But cloxacillin, roughly about 50 to 100 mg per kg per day. I always use the higher side, as I said. Cephalexin would be the same, 50 to 100. And the third drug was what, sir?
Amoxiclav.
Amoxiclav, typically 45 to 50 mg per kg of amox component.
Right. Thank you. So that's really, that's really great. So as I can see, most of the points related to staph infections are covered. And as I discussed or said in the beginning, prevention is very important. I always say that, as the staff in the hospital becomes aureus, that means when it develops aura, these staphylococcal infections become, much more common. So the staff also has to be very, very, particular about all this, and the prevention by following all those steps of the hand wash, okay, and then washing the hands, keeping the wounds covered, reducing the risk of tampoons in some cases, avoiding sharing of the personal care items, and cooling and storing of the food properly. So all that would probably be extremely important in prevention of staphylococcal infections. And you already mentioned about the role of nasal mupirocin in particularly ICU settings, where I remember sometimes the staff nurses also are made to use it so that they do not transmit the infection from one to other. So I congratulate you for a brilliant presentation, and I hand over the proceedings to Dr. Surekha Kare.
Yeah, thank you, sir. As we conclude today's Pediatrician Pathshala Scientific Convention, Module 2, Issue 1, which was on a case-based discussion on Staph aureus infections, So we extend our heartfelt gratitude to today's our speaker, Dr. Vidya Krishna, for her insightful and impactful session with different cases. We also express our sincere appreciation to our Dr. Pramod Jog, who is scientific coordinator, today's moderator, and a visionary behind our Pediatrician Pathshala platform. The synonym of Dr. Pramod Jog is Dr. Pramod Jog, who is joyful Dr. Jog, who is master in skillfully guiding the session as always. Before we close, a gentle reminder to all the pediatricians who joined us today, you can download your participation certificate from the Pediatrician Pathshala platform with just one click. And we look forward to seeing you again in our upcoming Module 4, Issue 2 on pediatric infectious diseases, featuring another exciting topic with another speaker to enrich pediatric practice. We'll be seeing you next month. Thank you once again and have a wonderful evening.